Assalamu alaikum. I'm sorry for coming late, traffic, and we did not have access to the hospital. So today we'll discuss retinal vasculitis. This lecture is, in my opinion, is very important lecture because it covers so many things in uveitis, especially posterior segment inflammation. This lecture is based on a review that we published years ago, and it is not because we are the ones who wrote it, but this review is still a standard article for those who are interested to know about retinal vasculitis. So please read it after the lecture. So retinal vasculitis is a vision-threatening inflammatory disease that involves retinal vessels. So the inflammation is involving retinal vessels, and retinal vessels are important for the function of the retina. It can occur as a complication of an infection or neoplastic disorders, systemic inflammatory disease, and isolated idiopathic condition. Big list: bacterial disorders, viral disorders, parasitic disorders, rickettsial disorders. And when it comes to neurologic disorders, there are two main neurologic diseases that are associated with retinal vasculitis. Not many people know that multiple sclerosis is an important cause of uveitis and retinal vasculitis. We see in our clinics many patients with multiple sclerosis associated uveitis and retinal vasculitis. We have the disease Sussex syndrome, which is a microangiopathy of the brain, retina, and cochlea. This is, by the way, frequently missed disease, and even many neurologists, they don't know about it. Sussex syndrome. Malignancy can masquerade as retinal vasculitis, acute leukemia, ocular lymphoma, and paraneoplastic disorders. Big list of systemic inflammatory diseases that are associated with retinal vasculitis that will go through these diseases. Vasculitis can be limited only to the retina, and it can be like idiopathic condition like IRVAN. Most important is IRVAN. In ophthalmology, and especially in the retina, we are lucky because we have direct visualization to the retina. So we can diagnose retinal vasculitis based on proper ophthalmoscopy without the need to have biopsy. You just can see the vessels, if they are inflamed or not. So the retinal vasculitis, the retinal vasculature is accessible to direct visualization using ophthalmoscopy. The diagnosis is made clinically, and of course we need fluorescein angiography to study other complications. Keep in mind, you cannot diagnose retinal vasculitis unless you see vascular sheathing. This is the hallmark of the disease. I am reviewing many articles in the literature talk about vasculitis without vascular sheathing, just based on leakage on fluorescein angiography. Leakage on fluorescein angiography is not enough to diagnose retinal vasculitis because in ischemic retinal vein occlusion, you can have leakage because of the damage of the endothelial cells. In many conditions like severe diabetic retinopathy, you can have leakage because of ischemia. In patients with macular edema after cataract surgery, you can have leakage. So you need to have perivascular inflammation with exudate to diagnose retinal vasculitis, what we call sheathing or cuffing of the affected vessel. Like this. You need to have this vascular sheathing or cuffing together. If you see a colleague making diagnosis of retinal vasculitis without seeing this, tell him this is not correct. You need to see this vascular sheathing. This vascular sheathing, as I shall discuss, is corresponding to perivascular inflammatory infiltrate. Inflammatory cells are deposited. Therefore, it is called periphlebitis in most of the patients. Is that clear? This is the first point that you have to keep in mind. You need to see perivascular inflammatory infiltrate, which clinically will show as a vascular sheathing or cuffing. Most of the cases, the vasculitis is affecting the vein, so most of the cases it is perivasculitis, and in most of the cases it is peripheral vasculitis because most of the cases the inflammation is around the blood vessels, and in most of the cases the veins are affected, so it is periphlebitis. We have histopathology to support what I said, and the histopathology is coming from multiple sclerosis. The histopathology showed in these patients with MS-related vasculitis, there is segmental perivenous inflammatory infiltrate composed of lymphocytes and the plasma cells involving retinal veins. And this is corresponding to the clinical finding of sheathing. This is a proof that the sheathing is due to perivascular inflammatory infiltrate. Examples. You have to know that MS can cause granulomatous inflammation with mottled fat KPs, as you see in this patient. And this type of vascular sheathing in the periphery is typical for multiple sclerosis. This is, in fact, our main indication to do brain MRI in the clinic of uveitis. If you see such elongated vascular sheathing, this is highly suggestive of MS. And then, on fluorescein angiography, MS vasculitis typically show focal leakage, not diffuse leakage, like in Behçet or birdshot or tuberculosis. Is that clear? This is an important point that everyone in this room should know about it. If you see this finding in the clinic, you have to think about multiple sclerosis. Another patient, again, mottled fat KPs, pseudocyanicia. Sometimes MS, we admitted one patient yesterday with MS uveitis to receive rituximab. Sometimes can be resistant to treatment with mottled fat creatic precipitates, and then you can see the vascular sheathing and focal leakage. Again, this is another typical case of elongated vascular sheathing in a patient with multiple sclerosis with focal leakage on fluorescein angiography. We recently published a paper, which I think is a very important paper, on clinical findings and outcomes of uveitis associated with multiple sclerosis, with very nice clinical pictures. I would encourage you to read it, because the most common finding in uveitis associated with multiple sclerosis is this pattern of vascular sheathing. That was the most common finding in patients with uveitis associated with multiple sclerosis. Sarcoidosis, we have also histopathology to tell us that the vascular sheathing or cuffing is corresponding to epithelioid cells in the perivascular space. An example, this is mottled fat KPs. As you know, sarcoidosis causes granulomatous inflammation, and optic nerve head swelling is common in patients with sarcoidosis, but you can see here the focal perivascular sheathing or cuffing. This is corresponding to epithelioid cells, and just for your information, the patient on ICG showed this hypofluorescent spots. What could be this hypofluorescent spots? Anyone know? Granulomas. So the granulomas here can be shown only with ICG, not by fluorescein angiography, because the fluorescein did not show it. And in both eyes. Behçet disease, we have histopathology to tell us the vascular sheathing in Behçet disease is caused by lymphocytic infiltration. And this is example of a patient with Behçet disease with extensive vascular sheathing. And so if you do biopsy here, you will see a very vascular inflammatory infiltrate composed of lymphocytes. Barzillanitis, we have also histopathology to confirm this, and birdshot chorioretinopathy. Now, keeping this in mind, we have another entity that in the retina that can be caused by systemic vasculitic entities, such as systemic lupus erythematosus, Wagner's granulomatosis, polyarteritis nodosa, Church-South syndrome, and the cryoglobulinemia. But most common is systemic lupus erythematosus. Here, we don't see vascular sheathing. and there is no inflammation. But we have occlusion of the retinal arterioles by macrothrombosis. Then if you have occlusion of retinal arterioles by macrothrombosis, what do you expect to see clinically? Infections in the form of cotton wool spots. So this is the feature of this disease that I'm going to discuss later. And the occlusion is caused by macrothrombosis, not by the vasculitis. Fluorescein angiography is useful to image a patient with vasculitis because with active disease, active vasculitis, there is leakage of dye due to breakdown of the blood retinal barrier and the staining of the blood vessel wall. This is typical for active vasculitis. But the leakage is important to limit the differential diagnosis. If the leakage is focal, as I showed you before, it could be sarcoidosis or multiple sclerosis. If it is diffuse, involving all the blood vessels, the whole length of the blood vessels, so it could be Behçet disease or tuberculous vasculitis. But if you look carefully and you see that the capillaries are leaking, each capillary is leaking, it can be Behçet disease and Birdshot chorioretinopathy. So fluorescein is useful for the differential diagnosis. This is an example. This patient had vasculitis, as you can see here, with vascular sheathing that was due to tuberculosis. And then fluorescein angiography, you can see diffuse leakage. Fluorescein is useful for macular edema, optic disc leakage, to support the diagnosis of optic inflammation of the optic nerve. And it is most useful to tell us if the vasculitis is occlusive or not occlusive, to delineate area of capillary non-perfusion, which is important for the management. Because if the vasculitis is occlusive, in addition to medical treatment, you need to apply scatter laser photocoagulation to the ischemic retina to reduce the risk of neovascularization and vitreous hemorrhage. It will help you also to show neovascularization, second-retinal ischemia. And it can support the diagnosis of inflammatory branch retinal vein occlusion that we shall discuss later. Examples. So this is a patient of, do you agree that this is vascular sheathing? And when you have inflammation, you expect to see hemorrhages also. So this is a patient with tuberculosis that was related to tuberculosis. And fluorescein angiography told us that this retina was ischemic. So here, in addition to medical treatment with steroids and the full anti-TB treatment, you need to apply scatter laser photocoagulation to the ischemic retina. This is an example also of tuberculosis. Tuberculosis, by the way, is a disease that tends to cause severe occlusive vasculitis compared to other conditions, severe retinal ischemia. Here, you need to give good scatter laser photocoagulation to the ischemic retina. I'm surprised because some months ago I received a paper to review, submitted to a good journal, and the paper came from the Kingdom, and the authors wrote specifically to the case report that their vasculitis was ischemic, but they don't like to do laser because laser can cause inflammation. This is wrong. This is wrong. That's why I rejected the paper. So when the vasculitis is ischemic, with large areas of ischemia, you have to apply laser. Is that clear? Now, when you evaluate a patient with vasculitis, you can notice that the vasculitis can predominantly affect the veins and can predominantly affect the arteries. If it predominantly affects the vein, Behçet disease is the differential diagnosis, tuberculosis, sarcoidosis, MS. And if it is purely arterial, you have to think about acute retinal necrosis and IRVAN, and of course systemic vasculitic entities. When you evaluate, that's why I call this manuscript clinical approach. When you evaluate a patient with retinal vasculitis and you see many cotton wool spots, as we just mentioned, cotton wool spots are infarctions of the retina due to occlusion of the precapillary arterioles. There are two differential diagnoses in a patient with vasculitis with many cottonwool spots. Either systemic vasculitic entities, most commonly systemic lupus erythematosus, or Sussex syndrome, or the macroangiopathy of the brain, retina, and cochlea. So this is an example of systemic lupus erythematosus. So if you see a young female patient with many cottonwool spots with intraretinal hemorrhages, bilateral, this is systemic lupus erythematosus until proven otherwise. Is that clear? We should not miss this, because this patient, when was referred to us from Jeddah, was referred as a case of retinitis. So this is a classic case of systemic lupus erythematosus retinopathy. Then, if you do fluorescein angiography, what do you expect to see? Skim, but at which level? Occlusion of what? Arteriolar occlusion. You would expect to see occlusion of the arterioles, and that is what we have here. In fact, the visual outcome was not good. She ended with 20 to 100 vision after we referred to rheumatology, because the macula is ischemic. And you can see most of the arterioles are occluded. That's why she had infarctions. Another case, again, multiple cottonwool spots, but less severe. And if you do fluorescein angiography, you see occlusion of the arterioles. Another case, this is perhaps the most recent one that I have seen, more severe ischemia in the left eye. But you see here, if you remember the discussion with Dr. Noalati, when I gave the grand round about Purshers-like retinopathy. Of course, Purshers-like retinopathy will give a similar picture of multiple retinal infarctions. Now, how about Sussex syndrome or macroangiopathy of the brain, retina, and cochlea? And as I told you, even some neurologists, they never heard about Sussex syndrome. So this is a disease that affects young men, but can affect men also. It's a small vessel vasculitis causing microinfarctions of the retina, brain, and cochlea. So this is a triad: retina, brain, and cochlea. So the patients, they present also with neurosensory hearing loss. So there is a classic triad of encephalopathy, branch retinal artery occlusion, sensorineural hearing loss. Fluorescein angiography is typical, that I'm going to show you. This is one of the patients that presented to the emergency room, and then you can see here cottonwool spots, right? There's an article that showed once that even seeing one cottonwool spots in a patient who looks to be healthy can be a sign of a very bad systemic disease. Even one cottonwool spot. So this patient had multiple cottonwool spots, as you can see. And then on fluorescein angiography, this is typical for Sussex syndrome. You see occlusion of the arterioles, and there is localized leakage at the site of occlusion. This sign is typical for Sussex syndrome. Is that clear? Occlusion of the arterioles, as you can see it here, and there is localized leakage at the wall of the arteriole at the occluded site, and here. There's another patient, and here the ischemia, the occlusion was in the fovea, as you can see here. And again, look at the fluorescein angiography. It's typical. Multiple arteriolar occlusion, and fluorescein angiography will show you that at the site of occlusion we have leakage. Now this is the last patient. Unfortunately, she was a 16-year-old girl. She had history. This is the case was presented a few weeks ago. You still remember the case? It was presented here by Dr. Tariq. مش كنتوا موجودين ولا ها؟ So this is a 16-year-old girl who presented at presentation. She had neurosensory hearing loss, and she had branch retinal artery occlusion. We suspected the disease because, again, look at the fluorescein angiography, localized leakage of the retinal arterioles, and MRI suggested the diagnosis. We referred to neurology. They confirmed the diagnosis, and we started here on systemic corticosteroids and Cellcept. It's, by the way, not only vision-threatening disease, but also life-threatening disease. So the prognosis is very good if you give the patient immunosuppressive therapy in time. But always keep it in the back of your mind when you have a patient with multiple cotton wool spots. Now, intraretinal infiltrates. You can have a patient with vasculitis with whitish infiltrates. You have to rule out infection, but then if you rule out infection, it is pathognomonic for Behçet disease. So hypopyon, as you know, but here you can see this is a classic case of Behçet uveitis with multiple intraretinal infiltrates. They call it chalky white retinitis. It can be with or without intraretinal hemorrhages. On fluorescein angiography, they are silent. And diffuse leakage involving the capillaries. These cases can be misdiagnosed as viral infection. We have seen this. That this retinal infiltrate can be misdiagnosed as viral infection, especially for those who don't see many Behçet patients. I remember many years ago during Moorfield uveitis course, colleagues from Moorfield Hospital, they were presenting a case that they thought it could be viral retinitis because of this infiltrates. And because there was a session on case presentation. And according to them, they gave antiviral treatment, but no response. It tends to recur, and so on. So I told them, this could be Behçet. Most likely this is Behçet. And they kept quiet. And it happened by the mere chance that our colleague, Professor Marwan Abu Ammo, he went to Moorfield as a visitor. And he was in the clinic, and they told them, this patient had Behçet, was diagnosed by ElAsrar. So those people who do not see many Behçet patients, they can misdiagnose these cases as viral retinitis. But this is a typical situation that you see in Behçet. In fact, this retinitis patches can be the first sign of a flare-up in a patient with Behçet disease. Again, you see this patches, what they call chalky white retinitis, and also fluorescein with leakage involving the capillaries. Is that clear? Another patient with multiple patches, it can be multiple. It can be in the fovea. And we have seen patients that lost their central vision because of having these patches of retinitis involving the center of the macula. And it can be in the periphery. Look at this pattern of leakage. Each capillary is leaking. Now you can have vasculitis associated with necrotizing retinitis. So again, during the evaluation of a patient with vasculitis, you have to look carefully for necrotizing retinitis. It can be with ocular toxoplasmosis, which causes focal necrotizing retinitis, or acute retinal necrosis, confluent areas of necrotizing retinitis in the periphery, or cytomegalovirus retinitis in immunosuppressed individuals. So toxoplasmosis, as I said, it is a disease which can cause focal necrotizing retinitis, as you can see here, of course, with vitritis. And two segments, the patient can have also maton fat capes. And the blood vessels crossing the lesion are always involved with vasculitis. Like this is a patient with focal necrotizing retinitis, but in the periphery. So the vasculitis can be at the lesion itself or even in the periphery, away from the lesion. Like this patient has focal necrotizing retinitis, and fluorescein angiography shows occlusion of the blood vessels crossing the lesion. Cytomegalovirus, so it can develop in association with CMV retinitis, as you can see here, or it can be like frosted branchiangiitis in association with a patch of necrotizing retinitis in the periphery. So this is a picture that we shall discuss later, that we call it frosted branch and just extensive leakage involving the veins. And this is a patient, is a renal transplant patient with BCR proven GAN cycle very resistant CMV. So the patient had very aggressive frosted branch angiitis. So this is for CMV. Acute retinal necrosis, it is common in the emergency room, caused by herpes group of viruses in immunocompetent individuals. So classically, there is anterior segment inflammation that can be granulomatous, and then you can see occlusive arteritis. In this case, the vasculitis is involving predominantly the arterioles. And then you should be able to see the peripheral confluent necrotizing retinitis. Of course, these patients, they have also severe vitritis. If you do fluorescein angiography, you can see occlusion of the involved retinal arterioles. And this is another patient with peripheral necrotizing retinitis and occlusion of the peripheral retinal arterioles. So it is occlusive retinal arteritis with necrotizing retinitis. This is another example. You can see the arteritis, sheathing, and peripheral necrotizing retinitis. So this is another patient with very aggressive, in fact, he ended with retinal detachment, necrotizing retinitis, and if you do fluorescein angiography, severe occlusion. So occlusive arteritis is a part of acute retinal necrosis. This is after surgery and silicone oil filling. Now, during the evaluation of a patient with retinal vasculitis, you can see that there are aneurysmal dilation along the retinal arterioles and on the optic nerve head. Here you have to suspect Irvan syndrome, which is idiopathic retinal vasculitis aneurysmal neuroretinitis, and less commonly in patients, in elderly patients with sarcoidosis. So arterial macroaneurysms in elderly female patients with sarcoidosis associated with peripheral multifocal chororetinitis. So, but most commonly we see this with Irvan. So what is Irvan? Irvan is a bilateral disease. There is no specific cause, characterized by massive amount of hard exudates, and the patient can lose vision because of this hard exudates encroaching on the fovea, and also because of peripheral ischemia. Peripheral retina tends to be ischemic. If the peripheral retina is ischemic and not treated with laser coagulation, the patient will have neovascularization and vitreous hemorrhage and traction retinal attachment. So this is the right eye of the patient, and here we have vascular sheathing. In fact, she was seen in another hospital and no diagnosis was made. And this is the left eye, exactly the same, with vascular sheathing, massive amount of hard exudate, optic nerve inflammation, and the fluorescein angiography will show you the aneurysmal dilation. Are they clear? Huh? And this aneurysmal dilation can be also on the optic nerve. Is it clear? So this is Irvan. And this is wide field photography showing you peripheral ischemia and leakage from the disc and the aneurysmal dilations. The ICG highlighted better the aneurysmal dilation. For the first time, we treated this patient with, she did not respond to steroids, she did not respond to CellCept, so we gave her infliximab. So this is at presentation, and this is 10 months after infliximab. Complete resolution of inflammation. All hard exudates cleared, and she had 20/20 vision. And not only this, the aneurysmal dilations regressed. This is an important case to be published. I just was talking about Dr. Abir, that we have to start writing this, publishing this paper. So during the evaluation of retinal vasculitis, you can see extensive sheathing involving the retinal veins, and this is typical for frosted branch angiitis. It is just a clinical terminology, but it can be the result of so many diseases. It is not a diagnosis. It can be due to many diseases, as we shall discuss now. So this is what we call it frosted branch angiitis, that you have extensive sheathing of the retinal veins. These patients can be classified into 3 groups. The diagnosis can be lymphoma or leukemia that can masquerade. I forgot to add this case of lymphoma causing frosted branch angiitis-like picture. So it can be lymphoma or leukemia. And this perivascular infiltrate is due to leukemic cells or lymphoma cells. It can be associated with systemic lupus erythematosus, Crohn's disease, toxoplasmic retiноchoroiditis. I showed you one picture with CMV before. So there are so many diseases that can cause this picture, so we have to investigate the patient fully. If you rule out these causes in 1 and 2, then you can make a diagnosis of idiopathic disease in otherwise healthy young patients. Is that clear? So there is nothing called diagnosis of frosted branch. Clinically, it looks like frosted branch, but I have to rule out lymphoma or leukemia and other systemic diseases before I make a diagnosis of idiopathic frosted branch angiitis. Is that clear? Then we also reported that these patients, some of these patients have severe retinal ischemia, as you can see here in this patient. And this is another patient with frosted branch angiitis, ischemia of the retina, and after laser foot coagulation. So retinal ischemia is a major problem in patients with retinal vasculitis. So retinal vasculitis can be ischemic or occlusive vasculitis. And as I said, it is extremely important to study the retinal circulation in patients with vasculitis, because if the retina is ischemic, you need laser foot coagulation. Tuberculosis, as I always tell, this is the type of vasculitis that tends to be occlusive and very ischemic. Examples: this patient had occlusive vasculitis due to tuberculosis. Look at fluorescein, severe ischemia. Another patient with ischemia, but it's already the patient had hemorrhage. And this is a patient we discussed in the grand round. A patient had vascular sheathing. What are these? In the right eye, peripheral neovascularization, and then severely ischemic retina in the periphery, and leakage from the new vessels. So this patient needed laser foot coagulation in addition to medical treatment with steroid and full anti-TB treatment. And this is the patient after laser foot coagulation. Another patient, this again tuberculosis, severe vascular sheathing. As you can see, we cannot diagnose vasculitis without seeing this vascular sheathing. And look at fluorescein, severely ischemic retina. This is tuberculosis. And wide field angiography showing severe peripheral ischemia. And of course, patient had laser. We also published a short paper that we can see occlusive retinal vasculitis in patients with multiple sclerosis. This also can happen, but not as common. This is the paper that relate multiple sclerosis. Another complication of retinal vasculitis is inflammatory retinal vein occlusion. I always tell that if there is a picture simulating inflammatory retinal vein occlusion, it is behchet until proved otherwise. I was giving a lecture in Italy, and one of the doctors there, medical retina, her name was Elisabetta Bullotto, she asked me, when do you call it inflammatory vein occlusion? When should we call it inflammatory retinal vein occlusion? And the answer was very simple. If you have signs of vein occlusion in addition to vascular sheathing. Very simple. If you have vascular sheathing with signs of vein occlusion, this is inflammatory vein occlusion. Like this patient, you see, do you agree there's vascular sheathing superiorly? Do you agree that we have hemorrhages only in the subtemporal quadrant and no hemorrhage inferiorly? So this is a patient had branch retinal vein occlusion, and because of the vascular sheathing, it's inflammatory. And this is wide field photography. You see the vascular sheathing? Hemorrhages are only here. You agree? So this is supratemporal branch retinal vein occlusion, and it is inflammatory because of the vascular sheathing. And this patient had behchet. So if you see inflammatory vein occlusion, this is behchet until proved otherwise. And this is the same patient with fluorescein. It's very ischemic. This is a patient, young male patient, who had what looks like central retinal vein occlusion, but when we looked carefully, he has also vascular sheathing. The patient was given infliximab, and he ended with 20/20 vision. So the diagnostic evaluation of a patient, what I discussed today is clinical approach to the diagnosis. In fact, I thought about this manuscript for several years because it was not clear, even for me, how should we approach a case of retinal vasculitis. So I thought that to limit the differential diagnosis, we have to approach the case from the clinical point of view, meaning that if the patient has cotton wool spots, perhaps this is the differential diagnosis. If it is predominantly veins, it could be this. If fluorescein leakage is focal, we could think about this diagnosis, and then so on. So the approach that I would prefer for patients with retinal vasculitis is based on the clinical signs. If the patient had aneurysmal dilations, if the vasculitis is very occlusive, so TB is a possibility. If there is inflammatory vein occlusion, so we could think about behchet and so on. So the diagnostic evaluation is often involves multidisciplinary approach and laboratory investigation. Frequently, we need to refer the patient to rheumatology and infectious disease. When you evaluate a patient with vasculitis, the first thing that you need to do is to discriminate between, is it infection or non-infectious? This is a very critical question. Why? If it is infectious and you treat the patient with immunosuppressive alone, you will induce a disaster. If it is infectious like tuberculosis and you need steroids, and if you combine this with anti-tuberculous treatment, it's okay. If it is toxo, and you combine the steroids with anti-toxo medication, it is okay. But if it is toxo and you treat the patient only with systemic corticosteroids, you will induce fulminating lesions. So it's very important. The first thing that we need to do is to rule out an infectious etiology. Because specific immunosuppressive agents may be useful in immunologic mediated diseases or non-infectious diseases, but contraindicated alone in infectious causes without a specific antimicrobial coverage. So it is based on a differential diagnosis derived from detailed history, review of systems, physical examination. In my practice, I first examine the eye. And then based on my findings on examination, and then I start asking questions. Because the examination, for me, will limit the differential diagnosis. So if the patient had inflammatory vein occlusion, then I start asking about mouth ulcers, genital ulcers, skin lesions, and so on. If medical history, review of systems, or ocular examination suggests an underlying systemic disease, then diagnostic workup should be tailored for that disease. It's a big mistake. We have seen this. Patient come to the emergency room, and then a big list of investigations are asked, including rheumatoid factor, antinuclear antibody, and DNA. That means that the doctor who asked for this, he does not know what's going on. So he is asking for a huge list of investigations. That means that he does not have good differential diagnosis. The investigations should be tailored to your differential diagnosis. Like, for example, in uveitis, you have a patient with acute non-granulomatous anterior uveitis, which can be recurrent. Then your first differential diagnosis could be HLA-B27. So I ask for routine investigations, but the specific investigations that I need to do is HLA-B27. Absence of any diagnostic clues from history makes idiopathic retinal vasculitis most likely. And you have to make sure that you do not miss masquerade syndrome. I said lymphoma, leukemia can masquerade as vasculitis. Little additional information is gained by blind investigations. That's what I call blind investigation. Toxo, serology, syphilis serology, rheumatoid factor, antinuclear antibody, anti-DNA. I have seen this. Many doctors ask for everything. If there are no signs or symptoms suggestive of an associated disease, then the workup should be limited. This is the basic workup for all patients: fluorescein angiography, CBC, ElAsrar, blood chemistry, urine analysis, tuberculosis skin test, syphilis serology, and chest X-ray. This is the minimum workup that you need, but you might ask for a specific workup if you suspect specific disease. What are the complications of vasculitis and the prognosis? Cystoid macular edema is always a big problem. It's a major cause of poor vision. However, prognosis is good if you diagnose it early and treat it early. Macular ischemia, you remember the patient with SLE? You cannot reverse visual loss. So macular ischemia is poor visual prognosis. Peripheral capillary closure and peripheral ischemia, this is seen in tuberculosis mostly. So we have to be prepared to do scatter laser foot coagulation. Patients with severe ischemia, and if it is neglected, it can lead to proliferative retinopathy, like diabetic retinopathy, neovascularization, vitreous hemorrhage and detraction retinal detachment, neovascular glaucoma, and functional loss of the eye. Inflammatory branch retinal vein occlusion is also a complication, and this is usually associated with Behçet disease. Retinal arteriolar occlusion is seen mostly in patients with systemic vasculitic entities such as systemic lupus erythematosus. So in conclusion, retinal vasculitis is not only vision-threatening disease, but could be the first sign of a lethal systemic disease. Prompt diagnosis and the institution of appropriate treatment will help to control ocular disease and systemic disease. You need to have careful history, review of systems, physical examination to make the diagnosis. You might need the help of infectious disease or rheumatology or other disciplines. Diagnostic evaluation should be focused, guided by history, ophthalmic, and physical examination. Thank you very much for your attention. Any questions? So I encourage you to read the article. I think most of our residents, they have it. And those who don't have it, they can ask their colleagues to send it to them.